Yeah, welcome back. Welcome back, everybody, to webinar number 2.
Sorry, I fell asleep for a second there.
I can't see who's out there in this webinar space, but hopefully there's a few familiar faces from last time. But as I'm sure everyone's no doubt aware, successful periodontal treatment requires an ability to get patient buy-in, motivation, to do their share of the treatment to achieve long-term success in periodontal treatment. We've got to be able to get optimal patient home care, and that supportive periodontal therapies is absolutely paramount. So this month's webinar, we're lucky enough to have the expert in communication and motivational interviewing, Dr. Ellie Knight. So for those of you who don't know Ellie, Ellie is Otago graduated periodontist, initially graduating in BDS in 2005 and then working both private and public practice in New Zealand, Australia, and then she's gone on to do specialty training in 2013 and been the recipient of several scholarships and awards. And some of you may know her from her role as the Colgate Senior Lecturer and Professional Practice Fellow at the University of Otago. And I was actually fortunate enough to have Ellie as a tutor of mine in my postgraduate studies. So her field of research was in periodontal epidemiology and oral health quality of life. She's written several peer-reviewed publications in international journals, and she is a passionate provider of continued education for dental professionals, and she speaks in New Zealand, around the world. She's currently honorary clinical senior lecturer at Otago Uni, and she's actually part of the prestigious global education group called the Osteology Foundation, which is based out of Europe, and it's probably the global leader, all things implant and regeneration related. So with this, I'll hand it over to Ellie to speak on communication and treatment planning. Thanks, Ellie.
Thank you, James, for that very enormous CV. Thanks everybody for joining me tonight. I know it's late. I thought it was at 6, but it's at 7. So I really appreciate you making time today in your evening, probably making dinner, some of you, maybe having dinner, maybe sitting on the toilet, who knows? But thank you for joining. So this topic is something that I get really passionate about, and it's the most fun part of what I do, because when our patients first walk in the door, they're nervous, they're apprehensive, they're probably doubting you and trying to say, what is she going to say? Is she going to try to sell me something? But when they leave with a smile and you know that you've communicated well, it gives you such satisfaction. Not just that, when we have to provide treatment that is not exciting, it's not exciting like braces or Botox or, I don't know, veneers. Getting gum treatment is scary and you're going to be left with some side effects. So when I see my patients go through that kind of unpleasant journey, come out the other end shining, and I know even before my patients walk through that journey, I know that they'll have a great outcome, which keeps me going from loving this part of the job. The treatment planning part is going to be a very short part of the presentation. As you will see, it will be quite repetitive and quite simple. This is my team in Dunedin. Wonder if you can see my pen. I'm going to bring a laser pointer here. Yeah, that's me. That's my husband, Nick, who's a prosthodontist. This is Ness, my hygienist, and that's our practice manager. We are a growing team. Okay. So that's my social media if you want to follow. Yeah. So the first part of the presentation today is going to be on communication, which has got quite a lot more extensive list of things I want to talk to you about. So it's about looking at it from the patient's experience point of view. And I was fortunate enough to be involved in Poppy Horn, who's practicing alongside James in Auckland, her thesis project. A really good technique to use in your daily practice is called motivational interviewing. Most of you probably have heard of it, and most of you are fairly familiar with this technique. I'll go through it, and it will sound more or less it will be affirming what you're already doing rather than doing something new. I think most of us are intuitively quite good at communicating well with our patients. I want to also share how I explain what gum disease is, more specifically periodontitis, and how to make it jargon-free in a way that our patients can understand, and also segue nicely into some side effects that they will need to be prepared for. I'll also share home care advice, what I talk about, how I give my home care advice, and then a brief summary of my important side effects slide. And then the latter part of this presentation is going to be on treatment planning. It's going to be a couple of slides at the end on how we fit self-performed home cares and patient self-care into our treatment planning, what to think of during short and long-term periodontal treatment. So, what are the barriers that will help, that will go against us being effective communicators in the clinic? We've all been there. We are pressed for time. We are tired. We are running late. We have just had a really grumpy patient that you were being really nice to, but they were really shitty back at us. They hurt our feelings because we're all humans. And also, even if you're giving the best advice and it's tailored to the person, if the patients themselves are not ready, they're not going to be able to take that advice on. So there are lots of limitations as to why what we're trying to suggest might not quite get through. Being a specialist is in a unique position because when our patients come in to see me, they're not expecting treatment that day. They know that they're coming in for just consultation. So I've got the luxury of having 45 minutes to an hour, chat with them, have a really good look-see, be able to have some rapport, have a good chat. All those things do help me overcome the barrier. And of course, they're already overcome the initial barrier of seeing a dentist, and actually another barrier of taking on that referral. So it does make it a lot easier for me. But it means my patients are ready to take on some advice. And I have to remember that every patient that comes in through my door, it's their unique experience. I can't act like I've talked about the same thing 1,000 times or more. I have to treat it like I'm saying this for the very first time with the same level of passion and dedication. I feel that's really important. So in terms of what our patients are going through, having healthy gums, going from having had periodontitis to healthy gums is not just about having physical health. It's a lot more than that. It's about their mental and psychosocial well-being. It is very well documented in the literature that we now know having healthy gums and healthy teeth has a big impact on our psychosocial, social, emotional, functional, and general well-being. So what we're doing isn't just treating disease, it is improving our patients' quality of life. So this lovely lady here, a photo of Poppy here, this was her thesis project. So she has I think it was about some 12 participants who came to her appointments. They were just diagnosed with severe generalized gum disease with bone loss, so periodontitis, and they were asked to diarize their experience from the get-go until they have some perio treatment and stability. These diaries were written diaries, voice recordings, and videos, and they were transcribed. Then Poppy painstakingly went through all of them, and she coded them and came up with some themes. And this kind of study is also been done numerous times, quite a few of them in Scandinavia. So it wasn't a big surprise when Poppy's findings were very similar with what has been put out in the literature. They were strong themes, feelings of our patients' shame, regret, their hiding, concealing. And what we came away with the study findings was that every stage of the treatment, there are some things we can be a bit more aware of because we're doing this day in and day out. We get so used to the blood and the noise and the sounds, smells and everything. But to our patients, it's all very, very new and scary. Before they come into our door, our patients are actually already feeling pretty low by the sounds of how it reads. So they feel a stigma. They feel like gum disease with bone loss and those long teeth that are stained, that you see in cartoons or movies. It affects not them, but somebody else. And it looks a bit dirty and aged. There's also a part of them that has known that something was up for a long time. They will often say they hide their mouth when they laugh or smile. They pick and choose where they go. In fact, they often don't even tell their close friends or family that they're coming in for gum treatment. So there's a lot of shame and a lot of self-blame. What it means is that after reading studies like this, it made me realize I must do everything I can to not make them feel any more guilty. So the conversation doesn't dwell on how bad the findings are. The conversation will talk about the optimism and what we can do to make things better from today onwards. Also, our patients are feeling embarrassed about their state of gums. So you can read the writing here, available in the recordings later on, apparently, too. But people have experienced a lot of shame, concealment, and negative thoughts about their oral health. But there's also a part of them that places blame on other people. So we've all heard this, it's the previous dentist did this, or they didn't diagnose me. My parents had this, I brushed my teeth 3 times a day and flossed them 9 times a day, etc. So that's also a sign of them having known something might have been going on. They feel guilty. So you can see there's a pattern of feeling negative. Another important thing about how our patients are feeling at the time of the initial consultation before treatment is that they're feeling very anxious to find out what they often think is going to lead to me saying, oh, all of your teeth need to come out, or something like that. You're going to lose all of your teeth. That we can't do anything, or the cost was way above what they thought it was going to be. So you can read here, they are in a compromised position. It's quite a unique environment. You meet somebody for the first time and they have to be lying down with their mouth open for them to have a proper examination. Okay, so it means at our first appointment, when the patients come in and sees us, their ability to absorb whatever we've said is going to be compromised. It means they're trying to get used to this new environment. Everything is being bombarded in terms of their sensory awareness part, that you're going into a new room. And even if we feel like we've emphasized something so repeatedly, it's not you, it's not us that haven't said it. In fact, it's not even them that haven't even refused to listen. It's just that they are not able to take that on. So we have to keep reminding our patients about the important things over and over again, and make sure that we're not feeling offended by the fact that they haven't taken it on. So for me, the thing that I repeat every time, like a broken record, is using interproximal brushes. And I always make time to do it in front of the mirror with them, and me doing it in their mouth so they can feel how firm it is and where I'm doing it. Even though I'm doing this every single appointment with them, or at our third or fourth appointment, they're still like, oh, I wasn't doing that. My patients do that all the time. I'm sure you have that too. It's just that knowing that, okay, my patient was not feeling comfortable to take on my advice, when they're able to go acknowledge it, that they've taken on my message, that lets me know that we've got good rapport, and I was doing the right thing by keep repeating myself until the important points were made. So what about during treatment? During treatment, of course, they will feel a level of discomfort. And it was interesting to find that even if it wasn't physically sore, they were still going through quite a bit of emotional and mental discomfort. Even if we weren't hurting them, they were anticipating something happening. But then on the flip side, we also have patients that we do exactly the same thing to, and they are falling asleep in the chair. But most of our patients are feeling just uncomfortable, largely due to anxiety. What was helpful to find out from the study was when in the middle of treatment, while they're going through something, let's say I'm scaling, apparently it helps them a lot if we ask them, are you okay? Or you're doing great, hang in there. Those little cues that we give to our patients in the middle of the procedure when they can't talk to us to reassure them, it really grounds them too. So keep doing that if you have already been doing that. So finally, after treatment, this is how I'm able to continue doing my job as a periodontist, because my patients often ask me, gosh, how do you do this horrible job? You have to talk to them about bone loss. But it's because at the end of the treatment, or at least the initial treatment, I can see that they're feeling empowered. They feel like they've got the gum disease under control. They've taken a big part of that success, and they can see there is a light at the end of the tunnel. Also, because I've already talked to them about side effects they're going to experience, which is feeling sensitive on the teeth, so dentinal hypersensitivity, they will most likely get larger gaps between the teeth, some food impaction, and maybe visible black triangles. Those things they don't mind, because they come back and say, hey, you've already talked to me, they've happened. And what I say to them is, gosh, that's absolutely fantastic. Those are really great side effects we need to know that your gums are healing really well. So to summarize our patient's experience, it means it is okay to have great empathy towards our patients, and in a non-judgmental manner. So I'm not doing it because I'm not Mother Teresa, but I know the evidence says my patient is already feeling horrible. They might sometimes appear aggressive or unhappy or grumpy to me, but I know that they're feeling all these feelings, but they've still turned up and sat in my chair. So I'll be grateful for their time, and I will show as much empathy as I can. And in turn, we're more likely to have a stronger patient-clinician relationship. This means our patients feel more comfortable in the chair. Often that leaves us being able to treat them better ourselves. Those patients that make us feel really tense or very anxious patients also make us feel anxious, and it doesn't necessarily make us perform better. The more laid back and good rapport we have with the patient, the better my performance tends to be. So having a better rapport with our patients definitely helps. And evidence is strong on the fact that our patients are more likely to take on our advice if we have effective communication. So there's a big reason to have effective communication, although you probably knew. We already know how important effective communication is. So what is, in terms of how to have effective communication tools under your tool belt, what is one technique you can think about is motivational interviewing. It is, I believe, one of the only psychological therapy tools that we use in dentistry. The most successfully used one, sorry, is what I'm trying to get to. So it's usually my bedtime very soon. Go to bed at 8 o'clock when my daughter goes to bed at 8 o'clock. Anyway, so it was originally developed to treat excessive alcohol consumption, but then it has been adopted to be used in dentistry very successfully. And in dentistry, we use it for home care advice and smoking cessation. It's a very handy tool because it's not to say that you should use this tool. It's not to say you should use this stepwise formula. It's not to say that. It's just to give all of us a bit of a framework as to what it is that we need to do to have a well-rounded therapeutic relationship towards a goal that we're trying to get to with a patient. It is a good tool because it is a directive tool, meaning it's not a self-reflective tool. It's not one of those therapy sessions where you go into a room and you lie down on a couch, like in the movies, and the psychologist has got a clipboard with a pen, they're writing down your thoughts and they ask you, oh, how did that make you feel? It's not that kind of a therapeutic tool. It's a directive tool. In essence, we're trying to let our patients realize what it is that they need to do. And by our patients coming up with these ideas themselves, they're more likely to actually action them. And it was developed by Miller and Rollin in 1991. So it has 5 important principles, which I'm going to go in through each of them in a little bit more detail. The top one is expressing empathy, which is something that we've talked about. So we are trying to be good listeners and show that we're not judging. So for what's a good example? My patients will sometimes come out and say, I don't brush my teeth maybe once a week. I go, yeah, okay, thank you. I mean, like literally, I'm not trying to be saying, okay, thank you in a sarcastic way. I am trying to show appreciation for them letting me know. But I might not necessarily go into whether it's right or wrong. At the end, when I present my treatment, I might go into tweaking the home care to improve upon what we've got today. Or smoking. When they tick their smokers or vapors, I thank them for letting me know, ask them about their intentions of quitting. If they're not, then I'll just say, do you mind if we talk about it next appointment? It's really important for you to consider giving up because it has a negative effect on your gums, and so on. So, we all know how to express empathy. Number 2, developing discrepancy. This is a unique one for this tool, motivational interviewing. It means we have to let our patients know if what they're doing is, or what they don't want to do is wrong. So if they're not doing something that is positive, we have to let them know. That's what the tool is for. But when you suggest that they should be doing something, it's not a style of interaction. So we're not going to confront them for not quitting smoking, but we're going to just bring up the smoking. We're not going to hide it or trying to conceal something bad so that we don't upset the patients. We still need to talk about if they're smoking 20 cigarettes a day, but we're not going to be aggressive about it. We're just going to talk about it like facts. Next part. The next two go hand in hand together, avoiding arguments and rolling with the resistance. So avoiding arguments is simple. If you feel like the patient is being dishonest or they're actually, I don't know, trying to say things just to go against you, you just need to avoid having arguments and roll with it. If it is something that you feel like there's genuine dishonesty, say they're not brushing their teeth, you can see that they're not brushing their teeth, but they're saying they're doing something. Maybe they are genuinely brushing their teeth and it's not effective, but if it's in contrast to what you're observing, we just move on from that. We might say, hey, I might just come back to that at a later appointment, or move on from that. And this is a good framework to work with because it helps me realize, well, I'm not trying to avoid a problem here. I'm just rolling with the resistance because we want to confront the problems, confront the things, not getting an argument or get a negative experience out of our appointment together. And lastly, we are going to support self-efficacy by our patients. So it's quite a, I don't know, important looking phrase here, supporting self-efficacy, but it just means we are boosting our patients' confidence. How we do that is first of all, gauging their level of confidence in doing something. So interproximal brush use, we'll go through the home care together and I'll say, hey, how do you feel about using this after, and most of my patients will say, hey, no, I feel like it means my patient is very likely to use interproximal brushes, but very rarely, but sometimes my patients will say, no, I don't think I can do this. I feel like I can't get in, it's bleeding too much, whatever it is. Then I need to find a different way to get around those problems. Supporting self-efficacy also means because we're trying to boost our patient's own ability to do something, get them to believe in themselves, so they will be able to use interproximal brushes every day. So to boost that even more, when they come in at the next appointment, I will check what everything looks like and let them know how well they're doing and if there's room for improvement. As part of this motivational interviewing, I'm going to confront them about something that we could do better. So I will say, hey, we could tweak your home care down here. Let's work on that. So we are still working on things that need improvement. All right. So the next part is how I explain periodontitis to my patients. Periodontitis means gum disease with bone loss. So I go through the same spiel at each appointment, each of my consultation appointment, and I like the way I do it because it segues really well into their home care advice, why they need to do it, why it's so important for them to do it, and next, why they will get the side effects that I'm explaining. Okay, so this flow chart is just, your day-to-day, what you do in the clinic. First of all, you get the patient in the chair. You're going to do some intro examination. And for me, I'll be doing a periodontal charting. when I do my periodontal charting, I always like to explain what I'm about to do beforehand, because when you're poking and calling out the numbers, if our patients are aware of what the numbers mean, even before I start explaining something, there's already a part of what's going on. So I will have a look in the mouth. I try to make some positive comments. I often like to say they've got great home care, because often our patients have good toothbrushing home care. It might not mean that they've got great interproximal home care, but I will make a comment of good home care. And then before I pick up my periodontal probe, I will show it to them in front of the face. And I say, hey, this is a little ruler that will slip into the gums, and it's got little millimeter marks, and it's meant to go in up to 3 millimeters, but any number that's more than that means there might be something going on. So I will just let them know what I'm about to do. And then once I've done the periodontal charting, I will work out whether I need some supplementary radiographs. So I'll go and do that, and I often take clinical photos as well. Makes it easier for us to look at pictures and communicate there. So once I've done that, once I've collated all the information, then in my head, I'm making my diagnosis and a bit of a plan and a number of things that I need to talk to them about. So I'll be sitting them up, and we come to my desk together, and then I'll be drawing some pictures to explain what gum disease is. So I draw a couple of teeth that meet here with a contact point. And I say, I've measured your gums and had a look at your x-rays, and I can see your bone, there's been some bone loss. So that shows me that you've got a gum disease named periodontitis. It means it's just a fancy name to say there's bone loss around your teeth. And the cause is extremely common. Well, we all have plaque intatta, which is bacteria. Bacteria doesn't mean that you're dirty. We're actually more bacteria than human cells. We need bacteria to survive, but your body is a bit extra sensitive to having plaque and tartar sitting around your teeth, and your bone wants to get away from the area. So I'll draw where the gum line is, and then I'll draw what we're expecting the bone line to be. We expect it to be just underneath the gums. With my little ruler, I'm not expecting the tip of my ruler to touch the bone, but I can feel a resistance and I'll stop. And my ruler will only go in yay much. But with persistent plaque and tartar buildup, in certain individuals, the bone will want to get away from that assault. And as that happens, where the bone has been lost, we've got more surface around area around the teeth for the plaque and tartar to dig into. And now we have this area that no matter how good our patient's cleaning is, they can't clean under the gums. So the vicious cycle gets set up where plaque and tartar is built up and the body likes to get away. So that's why when we go around their mouth with my little ruler, my ruler goes in a bit further. If my ruler is going down deeper than 3, usually means the bone has gone down a bit. So I've just explained what the charting is and what the bone has done, where the gums are sitting initially. So the gum disease, periodontitis formula, is extremely simple in that we have this formula where we know we can't change the genes, but we can change the plaque and tartar levels. And by removing plaque and tartar away, then we should be able to arrest the bone loss. So then we get to what the bone is going to do. Will the bone grow back? And very simplistically, the answer is no. We can predictably stabilize the bone loss, but we won't be able to grow the bone back. But what the body does, without doing any surgery, without cutting away anything, when all the debris is gone, it will want to re-establish this relationship where the bone and gums are really tight together. So over time, the gums are going to shrink towards the bone, which means now we've gotten rid of those deep nooks where plaque and tartar sit and nobody can clean it, and it will cause further bone loss. So this is what we're trying to achieve, some gum shrinkage and healing and healthy gums. So then this segues in nicely into then they'll have, this is why they're going to get larger gaps between the teeth if they've lost bone here, of course. So larger gaps. Because I've scraped away all the stuff that's stuck on their teeth, they will get a bit more sensitive to cold. The cold sensitivity tends to be transient, so I usually say it should be gone in about 3 months or so, slowly. The other reason why the teeth get sensitive is because the gums have receded a little bit and a little bit of roots can become exposed. But as you can see, these are very positive side effects. It means the gum disease is gone. It's stabilized. So this is our treatment goal. And my patients hopefully understand what it means when we have deep pockets. It means the debris being trapped. So after I've done that, then I'll go through their home care advice. So because the cause of periodontitis is dental plaque and tartar, and because our patients can't remove tartar themselves, we can only ask our patients to remove plaque at home. And with effective home care, we can really help stabilize the gum disease treatment outcome for a long, long time. Our patients often walk in having really good toothbrushing technique, whether it's a manual toothbrushing or using an electric toothbrush. I often find that they're pretty clean that way. It's just that often my patients haven't been using interproximal brushes, so I will always make a point of introducing it. So I will typically say, like with their photos up on the screen, I can see your teeth are beautifully clean, your home care is very good, but there is room for improvement in between the teeth, because on our charting, you can see that we've got deep pockets, especially between your teeth. And that's because in susceptible individuals, the bone loss will happen between the teeth because it's the area that we're most likely to not clean consistently. You know, we're all really good at brushing teeth, but not necessarily cleaning between our teeth. And so then I'll say we just need to get you to start using one of these tools. And then I'll show you this slide later on as well, but I will just show them how to use the interproximal brushes. As you can, I don't think I need to explain why interproximal cleaning is really important. Yeah. Okay, so I'm a huge fan of interproximal brushes. I don't tend to recommend flossing because of the reasons I'm about to share with you. And this is uniquely for my periodontitis patients. Our patients often have lost bone, particularly between their teeth. And unlike the buccal or lingual surfaces, between our teeth, there are a lot more concavities, and these concavities can be quite concave. So, for example, your upper fours, they're mesial. It's almost like it almost feels like a furcation defect. Sometimes it's that deep, and that's quite sharply deep. So often our patient's bone isn't somewhere up here like the rest, a healthy patient without having any bone loss. The bone's gone down somewhere down here, and the gums sit here basically this area has been exposed. So it's quite concave. And if we're not able to clean this kind of overhang, natural overhang area, they will likely lose more bone in there. Because flossing is going to completely skip through these areas, you can see even lower threes is quite substantial overhang like area where underneath the CJ, same with the incisors and so on. So that is a big reason why flossing is not recommended by me, because my patients are often over the age of 30. They're, a bit older than teenagers who are getting orthodontic treatment or, without any gaps. So flossing is not the best tool for my patients. Flossing is a great tool for patients who don't have bone loss and who have largely convex tooth surface. Whereas my patients who have lots of exposed concave surfaces, they have to use bristly things that can go in the concave area. So you can understand why I would be a great fan of interproximal brushes. And when I do get an interproximal brush, I want to pick one that will feel snug as it's going in, like the bristles are engaging the tooth. If a wee brush is going in and you feel like you can't feel that it's gone in, then it means it's too small. You need to go to a bigger size. And I don't like to choose like 7 different sizes for one mouth. I would like to pick maximum 2 or 3 that fits most areas. So you want to also reassure your patients that the same stuff needs to be removed between the teeth, like the stuff that we're trying to remove with toothbrushing. So you do need to brush vigorously also and scrub at each tooth. So this is a demo of how this is a more unideal way of interproximal brushing. So if I may play that again, it's just sort of poking the food out, but it's not necessarily cleaning each tooth. The way I would like my patients to use it is go in the gap with an interproximal brush, lean against each root, each tooth, down into the gingiva. So you're leaning against each tooth. I've used a smaller brush to demonstrate where I'm leaning to, but I would definitely pick a larger interproximal brush for that side. But you can see you want to lean the bristles against the tooth. You're not trying to lean the wire against the tooth, but you're really trying to engage the interproximal each individual surfaces. So as I'm explaining this, I am actually holding a mirror with them with a wee interproximal brush in their mouth, showing them. And then I say, hey, don't worry if your gums bleed. Sometimes it bleeds so much it puts you off, or sometimes you wonder if it's ever going to stop, but it will stop. It's a little hump they need to go through before the gums will completely stop bleeding every time they clean between the teeth, and it will take about 3 to 4 times. The other thing they need to know is their gums are healing just by using the little interproximal brushes. Because they've made their gums bleed, the gums will be a bit achy, especially at nighttime when everything's quiet. They might feel a little bit throbby. If it's worrisome, take some Panadol and Nurofen. Otherwise, just know that it will go away. That sort of feeling of throbbiness can last up to 2 weeks. And lastly, and probably the most important from our patient's point of view, is when they start using interproximal cleaning tools, they will notice slightly bigger gaps. If it's a type of patient that you only recommend flossing to, as in they haven't lost any bone, they're not going to develop interproximal gaps. They're not going to develop black triangles. So you might not need to go through this. But if it's a patient that you're recommending interproximal brushes, they're big enough gaps for that to go in, then they will notice slightly larger gaps, not big, giant train tunnels, but slightly bigger. So when you sort of suck in air between teeth, like that kind of feeling, they will be able to feel air going through between the teeth. For some people, they can be very alarming. And if you don't tell them this before they start using the interproximal brushes, this will be one of the biggest reasons why they stop using it. Apart from bleeding gums, they'll start noticing gaps get bigger, so they think they've worn something down. But because we've just gone through the diagram of the gums between the teeth will shrink, and if they're healing, they will definitely need to shrink. So if they can understand that, then you can segue into saying that this is definitely needed. It means your gums are healing even before they've had any treatment with me, by having effective home care. So these are the expected changes. See, this patient has got very big black triangles between their front teeth. You would have to have quite severe bone loss around these anterior teeth to have this much of a black triangle. But from, professional point of view, we appreciate that's what's happened. The gums have shrunk against the bone. They're black triangles. But also, please be reassured, this is not our usual everyday perio patient. This is quite a severe case. Okay, so this is probably a 2-minute ending treatment planning slides for those who stuck around thus far. So treatment planning for perio is pretty simple if the patient has come in for periodontitis. So I like to think about why I'm doing something or why the disease is there, always peeling it back to whys. So it has to make a logical sense to me. Also, for me to consider kind of punishing my patients with surgery or something a bit more unpleasant than non-surgical periotherapy. I would like to think about whether if I did something, whether it will have a positive, tangible effect on the long-term outcome of something. So often, for example, distal of sevens, if they have really deep pockets, I wouldn't necessarily want to do surgery there, because me having had visual access and me going in there and cleaning it once probably isn't going to make, to me, a tangible, positive change for the outlook of that tooth, as opposed to having done it non-surgically. So yeah, most of my periodontitis cases are managed non-surgically and have had really great success. Okay, so what are the things that go into periodontal treatment planning? The most important thing we need to consider is changing those risk factors that we can change. Number one is plaque control. I cannot emphasize enough how important our patients' interproximal care is. For any of our patients who've had periodontitis with a history of periodontitis, or those who are about to embark on their treatment, with interproximal brushing, a lot of things can improve. You will also find that when they start using interproximal brush for a few weeks before they come in and see you, because the gums have started to shrink a little bit or recede a little bit, you probably will be able to see subgingival calculus a lot better because they've become supragingival. Other modifier for risk factors like smoking, we'll be working on that together with our patients. And drug-induced gingival overgrowth is often a thing that I find with my patients with periodontitis. If they're on a calcium channel blocker, sometimes it really makes their pockets bigger because the gums are overgrown, so I can reach out to the GP and change that. So those, but the top one that we really need to help our patients with is their plaque control, encouraging them to do it daily, and letting them know that it's a lifelong project. They need to do it just as much as they do toothbrushing. Well, they just need to do interproximal brushing once a day, but they need to do it every day, like going to the loo or something like that. It just you can't not do it, because anyway. So interproximal brushing, so important. And then number two, we work on some short-term treatment goals, which is non-surgical treatment. Some clinicians may do surgery from the get-go. Some people might do a mix of the two. I always start with non-surgical treatment. Often the mouth is divided in two, so I numb up one side, do it, and then a week or two afterwards, I do the other side. The reason I do it that way is because I'm able to see how they're healing from the first side that I've done in the home care. And also it's very tiring physically. It's quite a lot to do the whole mouth at one go. It takes a lot of concentration and a bit of grunty work there. And then the long-term plan is what kind of maintenance schedule that we might put them on and whether they had more advanced dental intervention needs like pros, orthodontic treatment, or maybe flap surgery at those isolated sites that haven't resolved. So that's my very simple summary of how I schedule my review patients. After the completion of non-surgical treatment, I would typically ask them to come back in about 4 months to see my hygienist for review. So for charting, debridement, and then formulating their ongoing maintenance schedule with our referrers. And at each appointment, I think the most important thing, and it's repeated at every appointment, is emphasis on ongoing care, professional care, of course, but actually the most important thing is their home care. If they don't fall through with their good interproximal home care, they are very likely to have a great long-term outlook, even if they fall through a couple of times with professional maintenance. And I don't tell my patients that, but that's my observation. Okay, so on that note, I will finish the presentation. Thanks everybody for listening. And I'll wait to see if anybody's got any questions. Hello?
Hey, sorry. It's thanks, Ellie. It won't let me turn my video back on. The admin thing must not be oh, there you go. It's allowing me to do it now.
Okay. You doing that makes me feel a lot better about me turning off share screen.
Yeah. No, that's good. That was awesome. Thanks very much, Ellie. Yeah, very helpful, very informative, and yeah, I think there's quite a lot that we can all take back into our clinical practice, which is great. So thank you. There just had a couple of questions that did come through. One was, do you have a favorite brand or shape of interdental brush?
Oh, yes, I do. So I've used lots of different brands, really cheap ones from Chemist Warehouse, just whatever you can grab from the supermarket. Actually, supermarket ones aren't that cheap. Really cheap ones to quite premium ones. I think TPs are quite premium. And I've packed on the middle product, which is the Dental Pro one, because I think they all are disposable. None of them seem to last any longer, but I find Dental Pro bristles quite like plush, like quite not soft and floppy. They're kind of like plush. So I like them. Yeah, but you can just use whatever. Yeah.
Cool. Thank you. And do you provide or do you suggest any handouts for information after the consultation? And do you know any places to access any good patient handouts that you're aware of? I guess do you provide patients with information sheets to take away?
No, I just write them a letter. And I think that's kind of like a specialist practice thing, though. You know how you type up your treatment plan and it's got a spiel. So it's got the exact same spiel that I just said in that letter. So even in my letter, it doesn't really have any jargons in it. But no, I don't give them any handouts. I personally hate handouts. I never read them. Yeah, so I'm really lazy, so I kind of think everybody else is like me. So no, there's no handouts. Do you give handouts?
I give them, like, I do the letter as well, but give them, how you went through your little picture.
Yeah,
You're explaining things. They get
yeah,
like a copy of that picture. But
yes.
other than
That's
that,
really nice. Yeah, sometimes I make my patients take a photo of it because we scan it and we keep it
yeah,
records. So yeah,
yeah, I scan it and then I give them the copy, so it just goes.
uh,
Yeah.
oh
But
yeah.
anyway, but yeah, that was those were the only two questions that did come through. So yeah, once again, massive thanks to Ellie for the webinar tonight. It was great. So for everyone, the next session is on the 8th of September, so next month, and that's going to be presented by Dr. Frances Ruderman, and she's a periodontist based in both Wellington and Palmerston North. So the topic next month is going to be on risk factors associated with periodontal disease. And discussion, I guess, of these risk factors can be complex, difficult to manage, and sometimes a wee bit overwhelming. So Francis is very skilled at making a complex topic much easier to understand, and I'm actually looking quite forward to hearing all about it, the updated understanding on how these risk factors can be managed for us in our daily practice. So once again, thanks everybody for logging on this evening, and we'll see you guys all in a month's time. Cheers, and thanks again, Ellie.
Thanks.